Session 10, Congenital Heart Diseases. Session Overview. Congenital heart diseases, CHD, describe a number of different problems affecting the heart. The defects can affect the interior walls of the heart, the valves, the arteries, the veins, and that carry blood to the heart or out of the body. So congenital heart diseases change the normal flow of blood through the heart, are classified as cyanotic or acyanotic, and we'll be looking at what is involved here. In this session, students will be introduced to congenital anomalies, their clinical manifestations, management of these conditions. By the end of the session, for our goals and objectives, students should be able to identify the types of congenital heart diseases, distinguish between cyanotic and acyanotic heart diseases, identify the etiology of congenital heart diseases, describe the clinical manifestations, and management of newborns with congenital heart disease. Sessions outline. The key topics to be covered are congenital heart disease in general. We'll look at an overview of what an acyanotic and a cyanotic heart diseases are. We'll take time to look at some typical examples like patent ductus arteriosus and tetralogy of Fallot. Here, it is very extensive. Time will not allow us to do all in this session, and you'll be required to read further to add. Congenital heart diseases. Topic 1. Congenital heart disease, by definition, is the problem or heart defect in terms of structure and function that is present at birth. Prognosis. Congenital heart diseases causes more deaths in first year of life than any other birth defect, because the heart is a central pump of blood, and we all know that blood is life. So anything that has to do with the heart is very fatal to a large extent. So causes, here we have actual cause is unknown. So we have some related maternal factors and fetal factors, as I have outlined here. So you see that some conditions in the mother, or poor nutrition in the mother, or even consumption of alcohol in pregnancy, and then with the fetal risk factors, we see that it comes most of the time in association with other syndromes. So we have congenital heart diseases. The following are the most common congenital heart disease, and I have here the acyanotic, that is what those that are not associated with blueness or oxygen deficiency are the acyanotic heart diseases. An example, I have the aortic stenosis, the patent ductus arteriosus, and the ventricular septal defects. These and many more are examples. And then we have the cyanotic, which is associated with oxygen depletion and makes the newborn blue. And you see these outlined here. Notable among these, we have the pulmonary atresia, we have the hypoplastic heart, left heart, and then we have the tetralogy of Fallot, and then transposition of the great vessels, and then tricuspid valve atresia, and others I have listed, and many more you have to read and find out more. So clinical manifestation. On inspection, you see that the nutritional state will depict failure to thrive. There will be slow and poor weight gain, and there will be cyanosis in cases where the child has some cyanotic heart disease, and then pallor was also associated with pure perfusion. So you see that the hemoglobin level will not correspond with what you see on inspection because of poor tissue perfusion, And then also there will be some chest deformities and also unusual pulsation. The neck veins may be distended and visible because it's full and pounding. And clubbing of fingers, this is in association with all cyanotic conditions. The clubbing of the fingers are protruding outwards, and when you do this, you lose the diamond shape that you require because it's full. And then also we have palpation and percussion. And here the chest thrills are felt because when you put your hand on the chest, you feel it full and pounding. And then the abdomen, there will be some degree of hepatomegaly and splenomegaly, all because there is some enlargement in the liver and the spleen. And also palpation and percussion, you have peripheral pulse. The pulse rate is very full and pounding and may be regular, or you may have in cases where you have some regular irregularities, or you may have also some irregularities. And then also on auscultations, the heart rate and rhythm, you see that the heart here, there will be fast, that's what we call tachycardia, or slow, what we call bradycardia. And like I said, there may be some irregular rhythm that you elicit, and some murmurs that you hear at the heart sounds. It will be muffled also. And diagnosis, these are all ways the diagnosis will be made. You can have chest x-ray, physical examination, and then ECG, and all the others I have outlined here, including some physical symptoms that may be exhibited. Treatment, they may differ. Many defects need to be followed up carefully. A small atrial septal defect, ASD, may heal over time. Other heart diseases may be treated with medication alone, and others may require heart surgery, as we have in VSD, ventricular septal defect, patent ductus arteriosus, TAF, tetralogy of Fallot. They may require surgery. And depending on the magnitude of the problem, the surgery may be one time or more than one heart surgery may be required. Indication for surgery. General symptoms for surgery are that there is some symptoms of congestive heart failure, and these you elicit by difficulty in breathing due to accumulation of fluid in the lungs. Indication for surgery. General symptoms for surgery, key indicator here is CHF, congestive heart failure. There is difficulty of breathing due to accumulation of fluid in the lungs. There is some arrhythmias, which is abnormal heart rates or problems with heart rates. And then also you may have excessive work on the heart. So it will affect the breathing and the feeding and the sleeping pattern. All these will indicate that there is a need for surgery. Prognosis. Surgical intervention, with that there is good prognosis, and a lot of them are low risk because there is some major advancements in heart surgeries. And today in Ghana we have a whole cardiothoracic unit where heart surgeries are done, and the success rates are very high. But when left untreated, complications set in. So there will be pulmonary hypertension, and then high blood pressure in the arteries that go even to the lungs. Bacterial endocarditis will come from accumulation of fluid in the heart and lungs especially, and then congestive heart failure, which may progress to death. It's very fatal if left untreated. Nursing management. Children with heart failure, we need to assess for congestive heart failure. We discussed the symptoms already, and also diagnosis, so that we will make the appropriate diagnosis and also plan, come out. So So in terms of nursing diagnosis, we have decreased cardiac output that will relate to the condition. And then in terms of planning our expected outcomes, we will have adequate cardiac outputs. That is what we strive to achieve. And in our implementation, there will be numerous nursing strategies we need to put in place. And evaluation at the end is that we want continuous assessment and evaluation. So you have to monitor vital signs, observe nutritional intake, monitor intake and output, and observe family behavior and support where necessary. So you need to read further to be able to make appropriate nursing diagnosis and formulate your outcomes and strategies appropriately. Nursing care plan. So we're taking a few examples. Decreased cardiac output related to structural defects. The nursing intervention here, you have to assess the vital signs, respiration, blood pressure especially must be done too early, and the heart rate. You administer cardiac drugs as scheduled and record side effects. And then accurate record of input and output, weigh the child at the same time, elevate the head to help with the breathing. So the elevation should be between 30 to 45 degrees, and organize your care to allow rest and educate family on child's condition. So we go on with our nursing care plan. Ineffective breathing pattern is another nursing diagnosis related to the pulmonary congestion or CHF. And here the intervention is that you assess the heart rate, the breath sounds, oxygen saturation. And then also administer humidified oxygen and record the rates and response to therapy, elevate the head, suction when necessary, and family-centered care, and also chest physiotherapy will be needed, especially in the care of the child. So now this brings us to our topic 2, a form of acyclotic heart disease. So this is patent ductus arteriosus. The ductus arteriosus is a temporal structure. Failure of its closure presents this problem. So here is a condition in which the ductus arteriosus does not close. The word patent means it remains open. So the ductus arteriosus remains open after delivery. So pathophysiology, we are saying that it's a temporal structure that should close, but it doesn't, and it affects perfusion to the lungs before. So it does not close. Ideally, during birth, the lungs is not functional, so it's there to help with the perfusion of the lungs. But after delivery, when the child resumes normal breathing, it's no longer needed. Soon after newborn is delivered, ideally it should close, and usually closes few days after birth, or failure to close will result in this condition, and it leads to abnormal blood flow between the aorta, the pulmonary artery, and 2 major vessels that carry blood to the heart. So here we are saying that it affects girls more than boys, and then the risk factors are some of the conditions I have identified here. We have the fetal risk factors, prematurity, Down syndrome, and the like, and then maternal factors. We have even malaria and other conditions like rubella, which predispose our children to congenital heart diseases. The clinical manifestations are listed here, which is easy to identify and understand, and then the treatment. And the goal is closure of the PDE. And here, the heart defects that are present and keeping the open ductus arteriosus is closed as surgery. And in premature infants, it is often within the first 2 years of life that this repair is done. And in full-term infants, it remains open after several weeks of life. So it may close, but in the absence of that, we Then it can be done through the closure can be done through a catheter, or surgery may be required. So this is reading list to help us to further enhance our understanding. An assignment. PDA is a cyanotic heart disease, true or false? List 3 other types of cyanotic and acyanotic heart diseases and read more to make notes. Now we're looking at tetralogy of Fallot, which is a cyanotic heart disease. This is our third topic. By definition, we're saying that it's a type of congenital heart defect, and there are 4 classical defects present at birth. There is pulmonic or pulmonary stenosis, ventricular septal defect, overriding aorta, and right ventricular hypertrophy. So you see that this is a major defect. So we thank God that this is rare and is the most common form of cyanotic congenital heart disease, though, and patients with TOF may have other congenital defects. So the risk factor is the same for all congenital heart diseases. The clinical manifestations are what I've listed here. There will be cyanosis because you know the extensive nature of the defects. It's acute episodes of cyanosis, or what we call blue spells, and squatting during the episodes is what sort of helps the child, and difficulty in feeding. Clubbing on fingers and skin or bones enlarged around the fingers to make up, and failure to gain weight. All these are indicated. And here surgery is done, and it's more than one surgery may be required. Palliative shunt, the first surgery, helps increase pulmonary blood flow and increase oxygen saturation, and the spells of cyanotic spells they have. And complete repair is done in the first year of life to correct the problem, and may be done at a later time. And then this involves closure of the VSD, and also the stenosis is widened to help with blood perfusion. This is our references that will help you to understand further.